And she's got a bag of supplements and she puts them on my desk. Literally, there were probably like 30 or 40 bottles worth of things on my desk. And I just looked at her and I'm like, so do any of these actually help you? And she picks out like 4 or 5. And I'm like, I just kind of like put my arm across the 5 good ones and the other, and I slid them all across.
I love that.
To the other side. And I was just like, I just looked at her. I was like, so I don't know how much this stuff costs. I know it's not cheap. Please, before you go buying anything else, please just call me or come in the office and make an appointment.
You're listening to the Restoring Human Movement podcast, where movement experts discuss the latest evidence-based practices to help you and your clients move with mastery. And now, your host, Dr. Sebastian Gonzalez.
Hey guys, it's Dr. Sebastian Gonzalez, again, your host for the Restoring Human Movement podcast. This is the third part of a 5-part series on where I'm interviewing the people who were the contributing presenters or the content creators for the Pro Chiropractic Online platform. That is the Pro Chiropractic Online CE platform. By the way, you can start to buy it now. If your birthday's coming up and you need continuing education, you can get 12 online, at least in California, and this covers ethics as well as documentation history, the needed hours. And California is one of the hardest, so we tried to hit California and Florida as kind of our metrics. Everything else will fall into that umbrella typically, but you need to check with your state first. So I'm really excited to put this program out, honestly, and I can't tell you enough that if I were to take this module, this exact module, within my first year of practice, or probably my first 5 years of practice, it will literally change the way I practice today. And I practice this way today, and it's amazing. It's amazing to see how you can reduce a lot of people's symptoms with flexion intolerant back cases by practicing in this mannerism. And so, although you guys might have things that work for you, my hope for this platform was to expose everyone to the things they might not know yet. And as I would say, open Pandora's box, so you start to figure out, there's something else out there, because we all get very buried in our clinical practice, and it's hard to find new things that might work better than what we're already doing. And I've been fortunate enough to run into a lot of these people through podcasting, and I know I've done a podcast recently where I talked about how podcasting improved my clinical practice. This is basically how. And so I kind of want you guys to have that same experience and just dabble in these people's contents, because it might just blow your mind. And so James Valcarcel is going to be the one on today, and he's going to cover nutritional-based aspects to the flexion-tolerant back. And true story, I did have a patient recently that they had some neurological-based complaints, and they said, well, what natural stuff should I be taking? What can I be eating to improve this or accelerate it? And I thought, there was a slide on this in James's portion. I need to go back to it, and I will email you back. And so I did. And so, again, I'm still learning as I go. I'm not intended to know everything, and all the presenters don't know everything either. We're just presenting things that work extremely well for us. Philip Snell is on there. He talks about, he goes over examination as well as other considerations with the back, epigenetics as well as figuring out why disc injuries might be more prevalent than we think, and why we need to start being really good at addressing them based upon is that a socioeconomic with how much money is dumped into addressing flexion-tolerant backs that we just need to be damn good at. We have Greg Lehman on here. We have Cody DeMack, who goes over some loading, which I know a lot of you have been emailing me about that loading one that I did with him. I think it was back in 122 or 123. Maybe it was 123. We do tend on recapping on that again, and I'm going to have him on again to talk about his portion of the of the CE platform, because he goes over strength conditioning aspects of it, where you can. I mean, there's a great case in there. We covered it in 123 a little bit, where it was a real patient that came in there, and we got to load him. I was the cameraman at the time, so I guess I didn't do it. He did it, but it was really cool to see that you can get someone very quickly back into acquiring load, and it's therapeutic. But we will cover a scaled down version of loading very soon here for those of you who requested it. So it seems like it's a big need, and it was a very interactive video. I didn't know I'd be watching grip so damn long. I was very intrigued by the thing. And so we're going to have on James today to talk about the nutritional aspects of it. And quite honestly, went through some of that, and I started realizing that you guys are probably going to be thinking the same thing I am. How does James have like a 95% cash practice? And so we went down that route a little bit. And sorry, I tangented a little bit, but honestly, I think it comes down to you got to know that the presenters in this platform are going to be useful to you, and trust me on that. And I guess it doesn't. The content really doesn't matter yet, because you're going to get into the nitty gritty of it when you get into the course. So I asked James to share a little bit about practice management with us as well as we went through this. So hope you guys enjoy it, and it will be live by the time this podcast is live. The platform will be live. Check with our website to see if your state qualifies for it, and I'm hoping that it just blows your damn mind. Here we go with the story first, then we'll get on to James. Now, one story I don't think I shared, or at least the topic fact I don't think I shared, was that I got a thing about sheet tension. And you know how you go into a Westin or a nice hotel and like all the sheets are nicely pressed and they're pushed into the sides and the bottom, and you get in there and it feels like the bed is hugging you? That's good sheet tension. That's good stuff. And I don't know if it comes back to like the babies like being swaddled and stuff like that, and dogs having their thunder jackets and whatnot, but I really dig good sheet tension. So nothing drives me more insane is when actually all the sheets are pulled out of the bottom. And maybe it's when I've been flipping around a lot, but either way, I got to set that thing under there. And I'm not saying I got to make my bed per se, but I got to have adequate sheet tension to actually sleep well. Other than white noise, I think sheet tension is one of the things that helps me sleep the best. All right, cool. Everyone, welcome on Dr. James Valcarcel. Say hey, James.
Hey, what up?
What's up? Thanks so much for this is, by the way, this is the first podcast I've ever been late to. There was children one time, a baseball team actually that I was coaching, and it was an 8 o'clock thing. Mm-hmm. And I showed up 30 minutes early, and the kids started showing up at 8, and I said, "You guys are late because you don't have your shoes on yet." So I'm an offender today.
It's all good, man.
So I thought I would have you on to. So this is actually the third part of a multiple part series where I'm interviewing all the presenters that are on the Pro Chiropractic platform, the online thing that we had all your notes go on, or your presentation go on. So I thought having you on would be really insightful for people who are listening to kind of figure out how nutrition can really play a good role in management of low back conditions and so on.
Sure.
Cool. Tell everyone about yourself who doesn't know you.
I live and practice in Florida. Finished at Palmer, Florida in 2014. I've been in private practice pretty much since I got out. 95% cash, very little insurance in here. You know, my patients that have PPO will offer them a super bill, but that's about it. I'm a certified functional medicine practitioner as well as in DC. Trained in the McKenzie method. What else? Familiar with Titleist Performance Institute stuff. I'm a level 1. Trained with DNS with Craig Liebenson, or Dr. Liebenson, and a bunch of people through DNS, Dynamic Neuromuscular Stabilization. Was involved in Motion Palpation Institute all the way through school. I should have taken my nutrition diplomate exam, and I'm pretty sure I should have taken my rehabilitation diplomate.
That you should have taken it?
Yeah, I haven't gotten around to it yet. Been a little bit busy. And I just finished a PSP for UPIT, the primary spine practitioner certification training that they started in, I think it was 2007. I think they started in December 2017.
That's a lot of stuff.
It's a lot of stuff.
Quick thing before we continue, because I hear fluctuations in audio. At some point it feels muffled, but I can't see if you're getting close or not. So if you can see me.
Sorry.
Yeah, so whatever you said, when you said sorry right there, it sounds great. So whatever you did there, keep it. Sounds great too.
All right.
Cool. That's a lot of stuff. So as you went through that, just as I'm going through like the presenters, I'm kind of asking them their educational background and so you've gone through a lot of stuff already. Were there any pivotal points in there where you're like, I think I'm going to start focusing on this as being a predominant thing, because a lot of your presentation was nutritional based.
Mm-hmm. Well, in my opinion, you can't really have one without the other when it comes to musculoskeletal issues, especially the persistent ones. And more often than not, there is some kind of underlying biochemical or nutritional component that, in my opinion, oftentimes needs to be addressed. And given the way I set my office up, 95% self-pay, I try to be able to offer all of the people that walk through my door some form of help. So we can't. I don't want to turn people away if I really don't have to. That said, if we're not getting home runs with somebody within 3 or 4 visits over about 2 weeks, I've missed something, or they need to be somewhere else. And I'm okay with admitting that. And I tell my patients that, listen, if we can't get improvement with you in a reasonably short period of time, something happened. I might have messed up. You didn't do your homework, or we need to do some further diagnostics of some kind, blood tests or imaging or something like that.
Yeah, I like that. It seems like so. I'm mainly cash pay too. I kind of feel the same way with you don't really have a lot of time to not get a result. It has to be very, very quick.
Yeah. Especially, I feel like the end range loading exam or the McKenzie method for musculoskeletal and classifying these things appropriately is really, really critical. And through their training, they like to tell you, you got 3 visits to figure out and classify it appropriately. Well, in the type of model that you and I seem to have, we don't get 3.
Yeah,
we're not getting the referral from the MD, and getting 12 visits paid on insurance. No, we've got to hit a home run as soon as possible, or else the patient won't come back. So yeah, we got to do better, and I think everybody needs to do better. But in the type of model we have, we certainly have to try and do better than the rest.
So then the type of home run you're talking about, what type of results from the styles that you're practicing? What type of results would you expect within the first day, at least?
Well, for example, last Friday, I had a patient with 2 years of dizziness with pretty much any and all head and eye movement, which was just awful for the guy. He's getting anxiety over it, and he's getting medicated for it and everything. And before he left, his mechanical sensitivities were extension, left rotation, and like a left cardinal field of gaze type thing, and he would get immediate symptoms. By the time he left, left cardinal field of gaze was not problematic, left rotation was not problematic, and extension were all not problematic.
And it'd been 2 years prior to that, and he hadn't.
Yeah, 2 years prior to that. And during that visit, I actually had a student from Palmer, Florida, who's studying the clinical neurology stuff with Dr. Chad Carrick. And we were talking in the office after the guy left, and he was like, "I'm really, kind of surprised you didn't hit harder on the gaze stability type exercises and the eye movement stuff." And I'm like, well, the patient, he clearly had a cervical spine issue. So I think that the nystagmus and the eye-related stuff and the migraines associated with that were probably secondary to cervical spine dysfunction, and they'll likely go away after you clear that up. And he was like, "Oh, that makes a lot of sense." I was like, "Well, yeah, I think so. We can make these things really, really complex, I think, or we can kind of simplify them. But in cases like that guy I just mentioned, can we find something that is useful for them? Hopefully within an hour and 15, 20 minutes or so. It's a new patient time for me. And if we can, send them home with it, load it, and come in, in 3 or 4 or 5 days or a week or something like that."
Yeah. So I'm just thinking when you're explaining that to that student that was coming through, when you're looking at classifying these types of cases, is there a certain ordered process that you tend to use before you start? Because, like you said, we can make these things really complicated for people, or we can kind of take this like the low hanging fruit type of thing,
Right. The question is there what? Can you repeat that, please?
Is there like an ordered process that you'd kind of take, like the when you look at a patient come in the first time, what's going through your head when they're going through the history and everything, and then as you go into through the physical, like what are you looking for to be the first things to address?
Well, it depends on the chief complaint. If it's a musculoskeletal case, then we're going to be focused on musculoskeletal, and I think the end range loading exam is paramount in that. Typically, just straight up McKenzie stuff: derangement, dysfunction, posture, adherent nerve root, or other. With other being, are they having any red flags? If they're red flagging, get them out or refer for imaging or whatever you need to do, but they don't belong in the office, more than likely. And then classify it accordingly. If it's derangement, cervical spine, thoracic, lumbar, shoulder, whatever, you'll be able to make it really, really terrible, or you can make it better, and it's a rapid thing. But it really depends on how well you follow that type of method. And I think that's kind of similar to like the SFMA type of workup, where they, stability motor control, or I forgot the other ones. I don't really use the SFMA too much anymore.
I know a lot of them end in rolling. Everyone's on the ground rolling every damn time.
Everyone's rolling, yeah. Yeah. But I think an accurate classification is really important. The pathoanatomical model is useful, I believe, in the acute setting. Like someone just got hurt, they had a fall or something, they're in the office 2 days later. But someone that had an injury, 6 years ago or something, okay, there's more stuff going on.
Yeah, and I think that's a lot of what I see. Like I honestly don't want a trauma case in my office. Unless it's like a disc, really, it's I really don't want the other ones. It's there's that acute healing phase I think that needs to occur, and it's not as easy to kind of unmuddy the water. There's a lot of responses going on.
Yeah, and I mean, if you treat any type of trauma stuff, if you treat like a acute whiplash thing, I read this on a forum the other day. There was a clinician that was starting manual therapy with a patient after acute whiplash. Person was rear-ended or something. And in my head, I'm like, what are you doing? You've got to modulate the chemical inflammation. This person has chemical pain, and that there's a classification right there. Is it mechanical or is it chemical? Doc, it hurts all the time, 100% of the day. Sorry about that. It hurts 100% of the day. Really? Does it get worse with movement? Yeah, but it's worse 100% of the day versus, no, it only hurts my shoulder when I go like this. Well, if it's all the time, it's clearly chemical rather. What are you going to do about it? Okay, here's ibuprofen, 800 3 times a day. After 1,600 milligrams, you'll start getting the anti-inflammatory benefits. Come back in a day and a half, 2 days, see if it's better with that. If that doesn't do what you need it to do, just refer them out. Do some short-term pain management.
Yeah,
they have a chemical inflammatory issue. We can do stuff with that, lasers and electrotherapy and stuff like that. But oftentimes, those patients who are at high-level discomfort post-trauma, they likely need medical attention.
Yeah, that's I'm glad we went through this analogy actually, because now we got the two boxes at least. We have the mechanical, and then we have those clear chemical ones. I know that this is I think is very sad. I think that McKenzie stuff is very it is very wow factor, and some people don't use it, and so before we continue on into other stuff, tell me your experience with some of the McKenzie based stuff. What extremities it helps with, or what ones you find it doesn't work with, which spinal conditions, just so the listeners can get a feel of maybe I should learn that a little bit of that.
Well, at the end of the day, I think. And this is a Dr. Craig Levinson thing too. N equals 1. So, no matter what you learn, in my opinion, you have to use what's appropriate for the patient in front of you. You know what I mean? If for some reason you're pretty sure you've got an acute disc issue with some radicular symptoms, if you can't establish a directional preference with a patient, the end range loading exam is inconclusive for you. Well, did you actually follow through with the protocol? How experienced are you with it? If you're someone that just took part A, the lumbar spine one, and you're trying to work on a cervical in the same way, the cervical spine's different. It's not going to be exactly the same. But in my opinion, the end range loading exam, when done appropriately for spinal-related disorders, is paramount. Unless it's not. You know what I'm saying? Like, if you can't establish a directional preference in acute disc or subacute disc, okay, that's fine. The evidence does not support things like traction. Really, there's not a whole lot of support for it. But I will tell you from experience, I've had patients, I can't establish a directional preference, and we put them in traction for a couple of visits, and then we come back to it, then we can find one.
Mm-hmm.
So maybe, quote unquote, creating a little bit more space was helpful for that person.
Yeah.
I don't know, but when it works, and the McKenzie, I guess the McKenzoids, they would hate for me to say this, because they'll say that McKenzie always works, because if you accurately classify the patient, yes, it does.
Mm-hmm.
But when you can quickly establish a directional preference, load it appropriately with the right force and direction, you can see some really, 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 really profound improvements and results for patients. And they love it, because they can self-treat half the time, if
right?
Not more.
I think that's the big part, and I know that with I take people into loading, weight loading, mm-hmm. resistance training loading pretty quickly, and mm-hmm. there's some people who are afraid, and at least I tell them that we have the safety net, that we've established a clear directional preference, and we can reset you whenever we want. So at least
right.
if it starts to trigger, then they start to understand a little bit of biomechanics of why they're triggering and what different types of things,
Yeah, I agree with that, because, I tell patients the same thing when we do, I do some pretty low-level, low-tech rehab, and I don't have, barbells, kettlebells and stuff. But I tell people, listen, if they're nervous and they got some high-level fear avoidance, well, one, that psychological aspect, rather, that needs to be addressed,
mm-hmm.
right? It's huge. But I tell them, listen, we're going to do this. Well, I can't do that. That was painful. That's what hurt me before. We're going to do it. And if you get hurt, you're in the best place you could possibly get injured. You've
right.
got someone that's pretty decently trained here to help you out.
Yeah.
And you can just slowly do the graded exposure stuff or the resistance, however you want to approach it. And you start at the bottom, and you end up wherever the person needs to end up. You're not going to get somebody that's benched 300 pounds just tore their shoulder in pieces with pec tear. They're not going to be benching 300 pounds within 6 months.
Mm-hmm.
And that's a long injury rehab. Start them off with 30, on the high end or less. And if they make it up to 100 in that first day of rehab, that's fantastic. Great job.
You mean just not doing it ever again is not the answer?
in my opinion, it is not the answer.
It's the easy way. It's funny, so some patients come in, I give them the option of I demonstrate a nerve traction model. And I'm like, nerves like about 8% tension, and beyond that, they start to get a little bit irritated. I'm like, so I'll chill them on the little stretchy band. Yeah. I say, look, you got two choices. We can help nerve slide to make it so you can actually move through that range freely and it doesn't hurt, or we can just not move. So that it's your choice, really. Either way, you're gonna feel okay. It's frozen there.
Yeah, and if you choose not to move, that's fine. You'll never hurt again. Until, God forbid, you have to run out of your house that's now on fire, and now you're going to hurt the entire way. You're going to hurt worse once you get out of the house, or you won't make it out of the house because you can't make it out because you can't move.
Right. Well, if they got the McKenzie loaded in there, then they can just rep it out after they get out of the house, and they're going to be okay.
That's right.
Yeah.
Yeah.
I'm glad to finally talk to you, by the way, after all the email correspondence on. I liked your presentation; it was really good, and
thanks, man.
You're so easy to work with the non-moving artwork that was on my side because I was opening it in the wrong format.
Yeah, you sent me that email back, and you're like, nothing's working over here, and I'm like, working on my machine. I have PowerPoint. What are you using, man? I know. I don't remember what happened.
I feel like such an idiot, because I know it takes a lot of time to. I get it. I've created a lot of content, and then if it's a stupid tech user error, I'm like I'm going to spend hours on this until I actually talk to him about it.
Yeah, when Ben called me up about this and we talked, and he was like, "Yeah, we want you to put together a 2-hour presentation. You have 3 weeks to do it." I was like, "What?" I was like, "Dude, I got a business to run. I got patients to treat. I got to go to Pittsburgh again.
Yeah,
I need some more time." And then I don't have patient hours on Thursdays and the weekends too. So I'd catch up on my paperwork on Thursdays, and then I'd spend 3 or 4 hours with both the laptops in front of me. The laptop that I use for work primarily, it's got another monitor attached to it. At one point, I found myself with 4 Firefox windows open. Each one had 8 or 9 like ResearchGate and NCBI articles in it. And on the part with B12 in the presentation and peripheral nerve injury and endoneurial hypoxia, I was up to my neck, and I think the Journal of Neuroendocrine Physiology or Endocrine Physiology or something, I forget which one it was.
Mm-hmm.
I could barely pronounce it, and I still can't. And I was reading it, and I was like, oh my goodness. At that point, I finished the slide. I closed all the laptops. I worked 5 minutes from the beach. I went to the beach for a couple of minutes, and I found a bar, had a beer. I'm like, all right, you got to stop.
That's so funny. I'm working on a little course right now, actually, for a workshop for in person. So some of my classmates, like, we don't see each other all the time, probably like your guys don't either.
Uh-huh.
And so some of them, like, they'll call me about some questions about their cases, and they're like, hey, why don't you just put on a CE thing, we'll just hang out at a bar. And we never see each other. I'm like, well, that sounds great. And then we started persisting with this idea, and so finally I said, yeah, I'll put it on, let's just do it. Come to my office, we're not going to go to a bar, we'll just hang out, everyone just meet, and like, it's a whole class party thing. Mm-hmm. And as I started to make it, I started realizing that, oh my God, this is more than I want to do. Because you start digging through stuff. It's hard.
Yeah.
So I feel you.
Yeah, especially, we've got information at our fingertips, man. And I said that to a patient the other day. She was a functional med case, thyroid, weight gain, whole 9 yards. And she's just got a bag of supplements she throws on my desk. And I'm like, ugh. And I'm like, the problem here is that you, and then and me too, when I pulled out my smartphone, I was like, we have access to anything we want. And we're going to read information from anyone and everyone. Some of it's probably terrible.
Right.
And, to start self-treating issues like yours, you could see the goiter in her neck too.
Oh,
you could see the growth.
I've never actually seen a goiter before. Is there?
Oh man, it's not like super duper often when you catch them, but when you can see it sitting across the table from somebody, it's like, oh, okay, well, yeah, we need some blood count. You know what I mean?
Yeah.
We got to get some objective markers. And I told her that. She was like, I agree 100%. I don't want to keep guessing. I'm like, yeah, you can't guess, man. Don't guess.
Yeah.
Don't guess this stuff.
If there was a good way to maybe screen out all of the information that is just not good anymore, because I know no one ever takes their web pages down. Mm-hmm. And I don't know, I've been definitely guilty of searching things too. But I had a patient recently that they came in and they had a lot of questions, and I answered them, and I think to the best of my ability and to get them in the right place to accept what was supposed to be happening. And I told them, I said, look, we've already gone all those questions. Do not go online and search this, please. Because it was a hamstring strain, she said, right? No bruising. And it was decreased with plantar flexion as well as cervical extension. And I'm like,
so
please,
she's got neural tension?
Yeah, I'm like, please do not look up hamstring tears.
Don't look up anything.
Because there's nothing there, right? You're not going to find anything.
Yeah.
So, yeah, don't.
Yeah.
I can only imagine what you deal with if you deal with nutritional stuff.
Oh my dude, I had a guy. I had a woman come in 2 weeks ago. Super nice lady. She's like 80 pounds right now. At her healthiest, she was like 105, 110. She's like, dude, I've been consistently losing weight since like 2015. I'm looking at her medical history. I have 80 pages of stuff I could sift through prior to her even coming in. Oh my goodness, this is crazy. And she's got a bag of supplements and she puts them on my desk. Literally, there were probably like 30 or 40 bottles worth of things on my desk. And I just looked at her and I'm like, so do any of these actually help you? And she picks out like 4 or 5. And I'm like, I just kind of like put my arm across the 5 good ones and the other, and I slid them all across.
I love that.
To the other side. And I was just like, I just looked at her. I was like, so I don't know how much this stuff costs. I know it's not cheap. Please, before you go buying anything else, please just call me or come in the office and make an appointment. Stop wasting your money because all this stuff's unregulated. There's no regulations behind that nutritional support supplementation.
Mm-hmm.
It's a multi-billion-dollar industry. And the evidence for nutritional therapy is very, very lacking. But then we've got a question: who's performing the research? What's the duration? Et cetera, et cetera, et cetera. Whose interests are primary there. You know what I mean?
Mm-hmm. Yeah.
But, it's crazy, man. Sometimes I play basketball, with the trash cans in my patient's nutritional supplements.
You just toss them in. Do you have a little hoop over there too?
I don't have a hoop. I have a small trash can. And I'm like, you know what? Show me that. And I look at it, and it's just maybe it's magnesium oxide or something, the equivalent of chalk, essentially. And I'm like, this is crap. Throw it in the trash. Oh, but yours is expensive. I'm like, mine's expensive because it works. To get the same effect of mine, you would need to take 30 of these that you bought and saved yourself half price to get the same effect as 2 of the ones that you got from me. Congratulations, you threw money in the trash. And I just want to I'm not going to do it.
Do you ever do? So I actually the main reason why I started this podcast 2 years ago is because at first it was like I didn't want to have the same conversation with patients over and over again. Like I thought we can get beyond it and just record it, and then we can ask more questions, and
right.
And so you ever think about just doing an example of all of the just label comparison or to all the common ones they come in with, so that you don't have to talk about it all the time. It seems like a common conversation.
I haven't thought about it. Maybe I should, but on the same token, I don't really advertise. I try and keep things kind of private.
Mm-hmm. You can make a private video.
Yeah.
I'm just trying to make it easy. I think I talked about push, pull, hinge, carry, etc. about 4 times this week for over 30 minutes each, and then I searched Dan John stuff on Draper's site, and I'm like, I'm going to find something. I'm going to refer to this, or I could just make one. I don't want to do this ever again because it's always it gets further away. It's like, okay, do these 5 things and break them into single arm, single leg, and they're like, but what else?
What?
It's always more. It gets drug in a little bit more.
Yeah, I know.
So, but yeah, the listeners can that podcast will come soon because I do plan on doing that one.
Mm-hmm. I had a colleague who was telling me, he's like, you should start a private Facebook group with your patients or something like that. And I was like, yeah, I probably should. I probably should, but then I know my phone will go off all the time. I don't know. I don't know.
Because of their messages or because of phone calls?
Not just calls, but I try and leave work at work.
Right. We know that's a good point. I think I enjoy some of the side projects, but I think of it as duplications of myself, so I don't have to I never make business calls when I'm not working.
Right.
But I think that I don't really love social media in that respect because I don't want to answer back, but I want them to actually read the thing that's there or listen to the thing that's there. So maybe a Slack page is something. Ooh, hello.
I got the video working. I had Skype open.
Yeah. Is that a yokum behind you? Is that 2 yokums?
Yeah, it's 2 yokums.
Oh, man. It's been forever since I've seen a yokum.
I hate to say it, but for a little while, I used them as a step stool for single leg stance stuff. I put a towel on them too, but yeah, it was bad. I still use them. They were obviously, but yeah, I probably shouldn't have said that.
Those are the oldest. I don't know. Has there been a new radiology book that came out since?
Not to my knowledge. I don't know.
Yeah. I don't know. Me personally, I'll second that. I don't take X-rays, nor do I really look at them. I'll send them out because I'm looking for something else, and I think the radiologist should read it.
I have the same exact train of thought. If you're, in my opinion, if you have X-ray in office, you're playing with fire. One of the radiologists at Palmer, Florida, Dr. Richardson, brilliant guy, super smart guy. We had a discussion one time, and he was like, man, this is why you've got to always double check all your stuff. And he sent me a paper, a chiro collimated in a thoracic spine or cervical spine, I think it was thoracic spine, and did not comment on artifact. It was super small, and he didn't comment on it. 3 or 4 or 5 years or something later, the patient came down with lung cancer, squamous cell lung cancer or something. Mm-hmm. And came back to the chiro for not being more thorough and commenting on and sending out for an overread about the little speck of whatever it was. And he got sued and lost his license, and it was a whole big thing. And the patient had, at that point, non-operable lung cancer, wound up passing away, if I remember right.
Mm-hmm.
And this guy's whole life.
Yeah.
So like when I send out, I have an imaging facility literally around the corner from my house. I could walk there in 5 minutes. I send patients there for any of my spine stuff, x-rays, MRIs. They have a neuroradiologist, CAQ certified, who's awesome. And he reads every single one. And they know, because I've requested, if you get a referral from me, this is where I want you to read it. Like 3 months ago, I got a read back from one of his colleagues. No offense to his colleague. It was just a generic garbage read. Mm-hmm. I'm not great with radiology, but even I knew there was stuff.
It was just template.
It was a template. So I sent it back and I said, read what I put in the bottom right of the requisition, please. Please have Dr. So-and-so, read the report, read the imaging. And I was like, and who read it? Whoever I was talking to at the imaging facility. Dr. So-and-so. And I was like, which is not the person requested. And they're like, yep. And I was like, and I had lunch with my rep and we discussed it, that every single one of my spine films should be read by him, please. So it got sent right back, and he calls me up and he's like, yeah, you were right. There was something there, blah, 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 blah. He's cool.
Yeah. It's, I know we spent a lot of time in imaging in school, but I remember someone saying like, you got to be on drugs to really see everything. It's a lot going on, and I don't spend the time I don't keep up with it. I shouldn't be reading it.
Listen, you don't want me reading your reports or reading your images. I tell my patients, listen, if you're coming back in tomorrow or whatever, if they're a freaky person for a short period of time and they want a wet read, I'll tell you, but it's not, I'm going to miss stuff more than likely.
Yeah.
I'll hit the big stuff. If we got an enterolisthesis or spondylo or something like that, or a large disc herniation, we'll find it. But you always wait for the guy in the closet, with no windows in his office that reads stuff hundreds of times a day and is talking to a microphone, spitting out a report.
Right.
Or the girl, rather. Female, man, whatever. Let the expert do it.
Yeah. Are you wearing French cuffs, by the way? Do I see I'm looking at the collar. I'm going to guess.
No, I don't think so.
French cuffs is like, I don't know, they'd have to be different than the actual shirt, right?
I have no idea. I got this shirt at a not expensive store.
If you have a chance to look up French cuffs, I have this one shirt, and it's the only reason I have cufflinks at all. And because I didn't realize when I bought the shirt that it needed cufflinks, and it's got supposedly French cuffs, and I'd already hemmed it and shit. And it's great though. I only wear it to the best weddings.
Yeah, I kept getting invited to weddings for the last year and a half, and I didn't even RSVP to half. People stopped inviting.
Well, that's not. Is your time of life where I think it's every time around 35, people tend to get 5 weddings a year.
I'm gonna be 33 in a month and a half. Oh my goodness. Yeah, I'll be 33. My girlfriend's cool. Our dog is cool. Her birds are cool. We're okay.
Side conversation, because I know that probably some of the listeners are thinking you probably piqued their interest with the 95% cash practice. Can you tell everybody about if just maybe some tips of how that can be done if they're looking to do something like that?
Well, you mentioned before, man, it sounds like you've done a whole lot of stuff, right? Mm-hmm. Yeah. Well, again, I don't want to be able to not be able to offer something to everybody who walks through the door. Mm-hmm. I know there's stuff I hate treating. Young children, female health, not for me. Period. Just I have zero tolerance for young kids that are screaming and crying and not answering questions. And female health is just it's too complex to me. Mm-hmm. I don't get it. I don't have any interest in it. So I'm not going to be good at it.
Mm-hmm. I feel like if I had female health issues, I'd want to go to someone else who understood, honestly.
Me too. I get males in here and, we'll discuss things like low testosterone, which is discussed in the presentation I put together. that's very, very important to talk about. A lot of people don't want to talk about it. It needs to be discussed. Oftentimes, especially persistent pain presentations involving men that have been on opioids. When we talk about it in the presentation, it's there. There's a link between low T and, persistent opioid use. And there's a link to low T and persistent pain. Well, what happens with people that are having persistent pain? What do they get put on? Survey says opioids. What can that lead to over time? Hypogonadism. All right, so we're going to have less testosterone. Oh, well, there's the cycle right there. So we found that, we supplement with some kind of testosterone, whether it's synthetic or bioidentical. I prefer using bioidentical because then we don't get the shutdown. We get improvements in pain profile. Yeah, so since you've been on T, how's your neck been? Man, it was like, it's like a 2 out of 10, man. It used to be a chronic 5. This is really good. Oh, cool. You working out more too? Yeah. You're running around. Yeah, you're better. Yeah, how's things at home? Great. Oh.
Do you fist bump them after that?
I'll give my patients a hug. We'll fist bump. I think I fist bumped like a 50-something-year-old woman today.
I just didn't know if higher T meant more fist bump, less hand hug.
I'll do both depending on the person. Depending on the person, you kind of gotta, like Tom Lotus says, Dr. Lotus out in Chicago, be a chameleon when you're in practice. Kind of, match the energy of your patient.
Yeah.
Mirror people. That's all the psychological.
We're actually. I'm going to come back to the T in a second here. We were talking over the last couple ones. I had Ben on, and then I had Phil on. And we're talking about just overall patient communication. And Ben, since he had interned over at Phil's for a long time, he said that he's the ultimate chameleon, coming in sounding like a good old boy to one guy, and then sounding a different way to a different person. So I think I'm finding that people that are succeeding in their business ventures are good at communicating. Yeah, I will definitely agree with that. I am not going to talk the same way I will to a 25-year-old construction worker, male. I won't talk to them the same way I'm going to talk to a 62-year-old female who's having her first ever bout of that. It's a completely different conversation. So
wording's completely different.
How would someone develop that? Is there any steps you took, or just happens?
I don't know. Maybe be a sociopath. That might help.
Right.
No. I've read a lot of books. Like how to make anybody like you in 90 seconds is a good one. Instantly connecting with people in 60 seconds or less are all really good. But a lot of it is psychological stuff and psychological, tricks and manipulative tricks that you can do, and not doing it in a way that's going to make somebody feel like they're getting manipulated or used, but just to help try and kind of connect with somebody on that level, to help them feel just that much more comfortable. Because people do business with those that they know, like, and trust. So if somebody knows you, well, how do they know you? They've seen your picture on your website or something like that, right? Well, next up, they've got to like you if they're going to do business with you. And in our case, I don't want to say we're salesmen, because I'm not a salesman. I'll take what Don Murphy says. We sell clinical excellence. We're trying to be the best. We're offering solutions to problems. And that's something I tell my patients. You're here because you need help, you need advice, and you need someone to give it to you straight.
Right. I totally agree with that.
That's it.
There was a phone call I had the other day that it was someone calling about a groin issue, and he was too far away for me. He could have come, but he was closer to Ben. And so this guy's talking to me for 5 to 10 minutes on the phone, and he kept asking questions, like more technical ones. And he said, "Well, is Ben really good? Is he gonna?" And I'm like, correct me if I'm wrong, but I think you're looking to feel that someone is competent. They're listening to your concerns, and that everything's going to be okay. Does that sound right? And he's like, "Yeah." I said, "Good. Ben will do that. Call him." And that was it. And I hope he goes.
I've looking for my water here. I have a patient that moved he's in San Diego, isn't he?
He is. Yeah.
Dr. Ramos, what up? I had a patient move from here out there last year, and I referred her over to him to continue care. And she went and saw him once, and apparently he was too expensive. Well, we all are, right?
Everybody's too expensive.
Everybody's too expensive. So she emails me, because we had stayed kind of in contact just here and there. And she emails me and tells me she saw someone else who offered her a 128 visit care plan over 54 weeks.
Oh my God. I couldn't imagine seeing someone that many times just talking to them.
I don't want to see that. I don't want to see somebody that often.
Yeah.
Oh, geez. And she was like, what do you think about this? I called her out. And, this was through email. And I read the patient bullshit. And I was like, don't ever go back. Call Ben. Yeah, he's more expensive. He will take care of you. I promise.
Mm-hmm.
Called Ben. We talked for a little bit. He remembered her. I was like, she's going to call you again. She never went to the other dude, 125 visits over a year, whatever it was. Actually, I called the California board on that guy and his office and let him know. But it's crazy out there in California. You guys are all,
how'd she end up feeling with Ben?
She's doing great. She's doing great.
Good.
He's doing great. He did his thing. He's working out in the gym that's connected to his office, and her overall function has gone up.
Nice. Yeah, I think that is something that's I'm curious about it. Like I don't really tend to like the analogy that I give people about the whole, like, I don't like talking about cost really with them too much, but they're like, well, my insurance is this and it's $20 here, and then we're just going to go blah 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 blah, right? And I'm like, look, if I put myself on my side, if you don't feel significantly better, I actually hope for 75% plus within the 4 to 6, but just because I don't know, I'm going to say 50, or less.
Yeah, under promise, over deliver.
Right, but I don't see why they don't see the relevance all the time of it'll cost probably about the same. It'll take you less time to get where you're trying to go, and you won't go through much mental suffering for this thing.
Yeah. I mean, sometimes I have a 4x6 whiteboard in my main treatment day. If I ever have anybody ask me about that, I say, okay, well, you can go to PT, because you were referred there. That's fine. It's probably double.
I think I might have lost you. You still there?
I'm still here. Can you hear me?
Yeah, I hear you now.
Okay, video stopped for whatever reason. I just said it's cool. I'll do the math out for people, and I'll say, yeah, you can go do your PT, 12 visits at $40 a pop for your copay, and you get what? Is it one-on-one? Are you going to get, people focusing on you? Are you going to get this, and this that we have to offer you in the office? You can go try it. Come back and let me know. Yeah, I went. It was like $45, and they did a hot pack and the electro thing, and they put me in the corner, and I did a bunch of exercise.
Yeah.
And I'm not saying that happens for everyone, because it absolutely doesn't. But that's what I've heard before. And I'm not saying physical therapy is bad, because it's absolutely not a bad thing by any means. But to hear something like that.
Right. Yeah. There's always. This is funny. This side story was I met there was 2 older PTs I met at a course one time, and they're about 50, 55, something like that. They've been around for a long time. And it was a DNS course, and we were I was mainly one of the only chiros there at that time for whatever reason. So I sat with them at lunch. We were talking stuff, and they're like, "So let me ask you, how are you going to use this?" I'm like, "What do you mean?" They're like, "Well, don't you just get like 3 minutes with each person?" And I'm like, "No, I'm like," and I explained how I practice and so on. And after a conversation for a while, they understood it. I'm like, "Wait a minute, how are you guys going to use this? Don't you guys just do hot packs and them?" And they're like, "Oh no, that's our other stereotype too." And I'm like, "Oh, got it. We all have that. All professions have this.
We all have that."
Yeah.
I was talking to a patient today, and he said the same thing. I'm like, man, there's bad chiros, bad PTs, there's bad plumbers, there's bad mechanics. Like,
yeah,
what do you do? You just go to people that you know, like, and trust.
That's right. I know we'll start to close this up here. I was actually thinking we go over more nutritional stuff, but at the same time,
yeah, sorry.
No, it's okay, because like you said, I think it's, do they know, like, and trust you now? Because I want people to hear the course. And we're not going to get through. I mean, you got a bunch of diagrams and explanations and studies in there. Like, we're not going to get through it all. There's no point in doing it.
Right.
But just on that same nutritional note, just for the nutritional novice, such as myself, what are maybe 2 or 3 things that I should maybe be asking the patient to figure out if that is going to be their, if a nutritional part is going to be a large aspect of their recovery or not?
What do you eat? Do you eat crap? You know, if you eat crap, you're going to feel like crap. You're going to be just systemically inflamed. You can throw a bunch of good quality supplements at them. They'll probably feel better.
Mm-hmm.
Everybody's nutritionally deficient in something. I forgot who did that work and shared that information. I'm looking it up right now real quick. Dr. Scott Shannon from iCamp at the Miller School of Medicine, Miami, 2014, shared with us, and I have this in the presentation, slide number 4, the percentage of the U.S. population not meeting the daily recommended intake for specific nutrients. So everybody's deficient for the most part. So what do you eat? If you eat crap, you're deficient in something. Second, for musculoskeletal issues, there is definitely an association between vitamin D deficiency and persistent musculoskeletal pain, especially back pain. So for someone new to doing this type of stuff and incorporating it in clinical practice, those are the 2 questions I would ask right off the bat. I test almost every single one of my patients for vitamin D. And not just for the benefit it will likely have. It's not always going to be that way. You know what I mean? Nothing's 100%. We're not building cars here. But for the benefits that you may see with musculoskeletal pain, for the anti-cancer properties, for the improvements in blood sugar metabolism, for improving sleep potentially, for the inflammation modulatory effects, and for how cheap it is when needed, I think you're doing your patients a disservice by not doing so. No offense. But I think it's that important. And Alex Vasquez, who said some questionable things and written some questionable things, regardless, you can't deny the guy is very, very, very smart. He will say, in one of his papers, and I'll quote, sub-therapeutic dosing of vitamin D is sub-therapeutic.
I like it.
So the adult human male uses between 3,000 and 5,000 IUs of vitamin D daily. I think the RDA is like 1,000 or 800. Maybe it's 800 in kids and like 1,000 in adults or something like that. So if you as an adult human male are using 3,000 to 5,000 IUs a day, and you're mostly covered up, it looks like you're wearing a t-shirt, shorts or pants. What are you wearing?
Pants. You caught me on a rare day. This is this is probably 10 days a year.
Yeah. So approximately maybe 30% skin exposure on you right now.
Right.
And if we use the sun to synthesize vitamin D via the skin, if we don't have adequate skin exposure and adequate UV from the sun, do you think you're ever going to hit that 5,000 IU daily just to replenish what you potentially lost, or that 4,000?
Yeah, I think so. Maybe I need to use my skin a little bit more often, kind of like we're trying to build the energy of a self-sustaining house. I need the sun's rays.
I would suggest getting a Speedo, running around the block for a half an hour.
This would be amazing. I like how you don't have the first 2 buttons done, so I know you're trying to expose a little bit more.
No, it's just comfortable, and I'm done with patients today, man. I'm done seeing people. Like, I have shorts on underneath this thing. I didn't know if my video chat was going to work or not.
Oh yeah. No. Oh yeah. No. Well, I should just go pantless. Actually, to be fair, I do have my pant legs pulled up into clam diggers. I don't know why this happened, but it happened. Probably because I ran in here. Yeah, you got me too. You got the flops on.
But yeah, so we had about 5 minutes of nutritional stuff with this.
It's perfect. It's perfect. I think. I mean, as I've always talked to the other guys about it, and I'm sure that the listeners, this is the 3rd time we're going around. I'll say it after I have you off there, but I really do think it's going to be a very, very, very useful platform for everybody. So I don't think throwing a couple spoilers in here and there is necessarily needed, but I want everyone to be familiar with the presenters.
Sure.
Okay.
Yeah. The first I want to say, because I have the presentation up in front of me, I think like the first 30 or so slides are basically running through the inflammatory cascade, I believe. And it's confusing. No offense, but especially for a lot of chiropractors, we get like, 6 or 8 weeks of biochemistry. But this is stuff we need to know about, because the inflammatory cascade, inflammation is what drives pain. It's also what drives depression and anxiety. So if you are treating people with persistent pain presentation, I mean, you see people with persistent issues, right?
Right.
How many would you say, percentage-wise, just approximately, might have an element of depression?
Oh, gosh. I think a lot, they don't always talk about it either.
Right. And are they not talking about it? Maybe because you're not asking about it?
I think that's fair. Surprisingly, I think, so I wrote a book where I revealed recovery from a back injury, and I shared the depressing parts in there. And after they read that, they also mirrored back their depression. So I think it was the not being naked alone thing. Yeah.
And, I personally, I can empathize with all of my persistent, low back disorder patients. I suffered a traumatic spondylolisthesis. I had chronic lower back pain with bilateral sciatica disc for like 10 years, and no one took an x-ray. No one ever found it. My extension was about 10 degrees in standing before I hung out with Justin Dean and took his CAP course.
Oh.
And he cleared it up in like 20 minutes. It was crazy.
You'll like this. I got stuck in traffic because I just came from his place.
Oh, yeah?
Yeah.
How's he doing?
He's good. We ate pad thai today.
Oh, cool. I said, hey, next time you hang out with me.
Okay.
But yeah, and I can fully empathize with these patients that are usually pissed off and usually depressed about it, especially when it's been long standing. I was an asshole for like 10 years. I lost a lot of my friends because I was cranky because I hurt all the time. And I couldn't do the stuff I wanted to do. I was a pretty high level soccer player in high school. I had to stop playing. I was a captain of my high school team since I was in like 8th grade. I stopped playing my senior year so I can run.
Yeah.
Like, that sucks. I'm not going to get those 10 years back.
Yeah.
I couldn't do anything. It sucks.
Yeah, I think it's really, there's a lot of things that are depressing, and there's paranoia with it. There's isolation. There's, I know I shared in my book that my girlfriend wanted to go to Italy. I wanted to go because I wanted to go with her, but I didn't want to go, And it's like do you want to be, at least for me, it's like, I don't want to talk about this damn back thing anymore. I don't want to be the center of attention. I don't want to go, type of thing. And so it, I think, affects other people. And it's, you don't want to, or I didn't want to be the one that takes someone else's fun away. So I think there's a lot of factors in it,
It's huge. And, and this comes back to the assessment and treatment of patients. Like when I was putting this presentation together about nutrition and back pain, or nutrition musculoskeletal pain, specifically back pain, I got to a point and I was like, there are so many things I need to talk about. And I ran out of time. and at first I'm like, I got to do a 2-hour lecture on nutrition and back pain. How am I going to get all the, what am I going to talk about for 2 hours? And I started doing it. And there's so much more to it. When you take into account the biopsychosocial model that we all need to become experts in if we're not already, or become more educated in if we're ignorant to the topic. And with that, what nutrition can do for those aspects as well. And I think these persistent presentations, there's so much more to it than just McKenzie. There's so much more to it than any exercise. There's so much more to it than nutrition. We've got to try, if you feel comfortable, kind of getting into the person's head and seeing where they're at. And sometimes these patients, they need referral for psych. And we need to be aware of that. Or they need, cognitive behavioral therapy, or, action and commitment therapy. We need to be aware of which patients fall where. And this kind of comes back to, how are we going to classify this person? Right? And this is something that Tom Lotus hits on really, really hard. And this is why I cited World of Hurt in the book from Annie O'Connor and Melissa Kalski. Because if you can't figure out the dominating pain mechanism in your case, those are the patients that are your number 10 on their list. They've been to 9 other providers. They've tried everything and they haven't gotten better. Why? Well, the PT did exercise wasn't helpful. The chiro manipulated, it wasn't helpful. They tried nutrition, wasn't helpful. Why wasn't it helpful? Nothing's going to help me. I'm never going to get better. Mm-hmm. Boom. There's a problem right there.
Yeah, that's a big one.
What do you do for fun? Nothing. My life sucks. Oh, wow. Wow. Why does your life suck? Because I can't do anything because my neck hurts. Does it hurt all the time? Yeah. 100% of the day. And you start digging. And some of these people, I've had a few of them. One of them was like this. When do you not hurt? When I'm riding my bike. When do you hurt the worst? When I'm doing chores. You hurt the worst when you're doing stuff you don't want to do.
Right.
What a concept. Or when you're laying on the couch and all you can do is perseverate about how bad you feel.
Right. I had an interesting lady recently that she drive a lot. She drove to LA area, and it's a long drive over here, depending upon the day. Just like why I got back. And she gets her shoulder necks really, really hurt when she's in the car, and she gets so bent up and frustrated. Yeah. And so I told her to put on something that makes her sing. Put on your favorite album. And that actually helps. I think you're right. I think there's a lot of parts to this, and I think we as clinicians just need to be able to navigate it well for the patient. I think we're guides, and we're not going to do everything for them. We're just guides.
Right.
So
right, and a lot of sometimes it's changing the thought process. Sometimes it's about managing stress. Sometimes it's about movement therapy, manipulation, all the stuff that we're really well trained in. But in my opinion, if you don't figure out the dominating pain methods, you're not gonna help.
Mm-hmm.
You're just not gonna help. And it's tough. It's tough to navigate that. But to become well versed and more educated on these types of topics, I think are really, really, really important for all of us as clinicians, especially with the patients that we tend to see. Oftentimes persistent spinal issues.
Nice. I think you cleaned up this interview very well. Learn more and know where to plug them in.
Yeah, well, don't stop learning. As soon as you stop learning, there's going to be a problem.
Yeah.
Stop learning. If you don't keep learning, you're going backwards. So
you're going to get those yokems out tomorrow, right? Is that what I'm like through to, like end to end yokem?
I've got like 5 cups of coffee I got to clean up first out of my desk. And, no, I'm absolutely not gonna. I'll probably hide those now.
I'm really glad on like wherever I'm at here, like no one can tell anything recognizable really behind me. If anyone picks this one, can you pick that one thing out?
Behind you?
No one's identified the single thing.
Looks like a Quest photo.
You're close. It's a musculoskeletal ultrasound of the femur, or the femoroacetabular joint. So
cool.
Well, right
I'm
on.
at work right now.
What's that?
I'm at the office right now, so I'm getting ready to get out and go home.
Yeah.
But man, hey, it was great to talk to you. Thanks for having us. Thanks for having me. Hopefully some people find some use for this thing that took me like 6 weeks to put together and many hours and headaches. But it's going to be brutal to listen to for some of it, for sure. I'm sorry about that. But there is good information.
I saw it twice. I only zoned out twice. How can everyone reach you?
Yeah, you can just email me at drjames@aihcenter.net. Website's www.aihcenter.net. That would be the best way to get in contact with me.
Perfect. Only on business hours, though.
I will not respond if I don't want to.
That's perfectly valid.
Yeah.
All right, so I'll pause this right here and I'll come right back. All right, thanks so much, James, for being on. That was great. I know we've spoken a lot on email, and I've heard your voice over and over again on that presentation that you gave me. But yeah, I like talking with you. You're a good guy. So cool. Thanks so much. And thanks so much for referring. Ben was the one who contacted James to be on this, so I didn't personally know James at the time, but love his stuff. And we have friends in common, so that qualifies you as an okay person. Now, again, if you guys are looking for this CE platform, go on to Pro, that is P-R-O, Chiro, Online CE. So that is Pro Chiro Online CE. There will be a link in the show notes for it. Currently, the platform is on Teachable. It's on Thinkific. We might change that at one point coming up in the future, but for the most part, it is an all video-based program. You have to go through it, and it will rack all your hours in there. And if you're looking for CEs, it'll present you with a CE credentialing at the very end. But for the most part, like I told Ben and Philip, I'm like, I don't think we should position this thing as mainly a CE thing. The CE is a bonus, honestly, because for the cost and being able to watch this in the comfort of my own home and be able to actually learn this quality amount of shit, I think we're selling gold nuggets is what we're selling. We're selling gold nuggets and opening Pandora's box for people. So our hope is that if you like those presenters, then you'll go. Some of them have courses. Like Cody doesn't have a course. I don't know why he doesn't, but Philip does, and Greg does. And into our next module, there's going to be people who have courses as well. And it's kind of snapshots into stuff that you'll be learning in there. So we can't possibly cover it since they're multi-day courses. But I thought we'd take some of the gold nuggets and the pearls of wisdom that we can definitely learn through that. So I'll talk to you guys next week, and leave people better how you found them. And if you're dating Eagle Scout, talk to you soon.